All right, NEXUS criteria. So when I say NEXUS criteria, I am specifically referring to cervical spine NEXUS criteria. There is now a head CT NEXUS criteria. There is a chest NEXUS, and there's probably other NEXUSes. But the original and the best is the NEXUS cervical spine criteria, and that's what the journal article I sent you was about. Is it worth doing an entire journal club about NEXUS criteria? Obviously, since I did it, then I think the answer to that is yes. It is a landmark article. And if you ask me, how do I assess if somebody needs to be imaged on their cervical spine? I simply ask, do they pass NEXUS criteria? Very easy. All right, so we're going to go through the article, and then we're going to talk about some of the more practical points associated with using NEXUS criteria. So you were supposed to read the article. So I will offer somebody a 5-pack of beer if you. I drank one last night. If you are willing to. If you are willing to summarize this article like in 1 minute or less. Anybody?
Unfortunately, at this point, the audio cut out, and so you can't hear the resident's eloquent summary of this article. But just to summarize what he said that the Nexus validation paper cited here was a prospective observational study of 21 centers in the United States. The study was designed to assess a 5-part decision rule. The 5 components of the rule are as follows: no midline cervical tenderness, no focal neurologic deficit, normal alertness, no intoxication, and no painful distracting injury. The idea is that if none of these criteria are present, then there is no need for cervical spine imaging. The study assessed over 34,000 patients in whom the criteria were assessed prior to the cervical spine imaging results. And the study found a 99% sensitivity overall and a 12.9% specificity.
In particular, you got the numbers almost right. So the overall sensitivity was 99% for any sort of cervical spine fracture. And then for what they defined as a clinically significant fracture, then the sensitivity was 99.6%, and then the specificity was about 13%, 12 point something percent. All right. So very, very high sensitivity rule. But we'll talk about a few of the strengths and weaknesses of this study. First of all, this study was massive. Over 34,000 patients at 21 centers. Centers including trauma hospitals, non-trauma hospitals, academic hospitals, non-academic hospitals, to sort of get the full spectrum of patients and providers. It's going to be hard to beat that as far as multi-center and size. Second, with regards to how you test a clinical decision rule, this is like as good as it gets. This is a model study for how to test the clinical decision rule. They had the providers at each place go through the NEXUS criteria before the results of the imaging of the cervical spine every single time, or so they claimed. I've done multi-center trials before. I will say that getting 21 different centers to actually do something is extremely difficult. Getting one center to do something is hard. Getting 21 centers to do something is extremely difficult and very impressive. Enrollment. So I really liked the way they did the enrollment. There are no exclusion criteria essentially in this study. If you had blunt trauma, then you could be included from any age. Any age, any sort of blunt trauma. So this makes this rule very easy to apply. Anybody, any age, with any sort of blunt trauma, you can apply NEXUS criteria. All right, and really you should be applying it to people who theoretically could have sustained an injury to their cervical spine, not like if they took a blow directly to the ankle from a soccer ball or something. Obviously, that's not somebody you would apply NEXUS criteria to. All right. So I think that those are all excellent strengths, and the results are hard to argue with as far as the sensitivity of the rule. At the same time, while I said that a strength of the study was the enrollment, a relative weakness of the study was that I don't know the total number of patients who they potentially could have applied this rule to. So we know that they used 34,000 plus patients, but it's possible that they could have enrolled 50,000 at all those centers or 100,000, and that they only enrolled half of what they could have enrolled. They don't give you that number of the potential enrollments, because it's possible that sometimes the providers were already deciding that this patient doesn't need cervical spine imaging, even though maybe they did, and so didn't get enrolled in the trial. In order to get enrolled in the trial, you had to have a provider who thought this patient needed cervical spine imaging. So in other words, some patients who may have been included did not get included just based upon physician judgment, which can affect the sensitivity and specificity of the rule. That being said, it probably affects it in a way that would be favorable to NEXUS. So this is a relative weakness. Now, clinically significant fractures is going to be debatable here. So did anybody catch what some of the clinically significant fractures were? Sarah, what'd you see? Correct. So for the recording, Sarah said that certain types of fractures, such as spinous process fractures or transverse process fractures, were considered clinically insignificant. The rule didn't care as much about catching those. And to me, this makes perfect sense. However, not every physician thinks like this. And there tends to be a divide between emergency physicians and trauma surgeons with regards to wanting to catch every injury versus wanting to catch injuries that really matter. And it, to me, is not important to catch a transverse process fracture in the cervical spine, because nothing happens with that other than they might have some pain. But somebody else might think, oh, if they have pain for a long time, it is worth knowing that they have a cervical spine transverse process fracture. So you could debate all day whether or not this definition of clinically significant is important or not. I'm on board with it, but certainly many others would disagree. The type of imaging is going to be the one that, as you read NEXUS 19 years after it was published, this is the one that you're going to argue the most about. So the vast majority of patients in the NEXUS study got cervical spine x-rays. Vast majority of patients that we image today get CT scans. So if you had repeated the study and you got CTs on everyone instead of x-rays, it is highly likely that your sensitivity here would be significantly lower. Whether or not the sensitivity for clinically significant fractures would be significantly lower, I can't say. But it's likely that the sensitivity will drop quite a bit if you CT'd everybody. All right. So a few other subtleties with the NEXUS criteria. Distracting injury. Did anybody catch how they define distracting injury? They did not define distracting injury. That is correct, Pavel. And in fact, in the discussion, they specifically state that didn't define distracting injury because they wanted to leave it up to the physician to decide if they thought the injury was distracting the patient or not. So there's not a specific injury that is distracting. In other words, somebody could have a broken femur and not be distracted. Another patient may have a bruise on their arm and be distracted. So the definition of distracting injury is, do you think that the patient is distracted by the injury? And I love this definition because it allows the clinician to use some judgment, but recognize that this adds a fair amount of subjectivity to the rule, right? So it's not clear necessarily who's distracted and who's not distracted. So if you're going to apply this rule, this is where things get slightly dicey. Right? So if you applied this rule and the patient had, for example, a femur fracture, and you didn't image their cervical spine because you said they didn't seem distracted by their femur fracture, but you missed a cervical spine injury, it would be pretty easy for somebody to say, look, this patient had a femur fracture, clearly they should have been distracted by that injury, even if you were at the bedside and you thought that they weren't, right? So that subjectivity is where NEXUS becomes a little bit tricky to use, all right? And so if you're ever on the border of whether or not something's a distracting injury, you should probably just proceed with imaging their cervical spine. That being said, I have not imaged people's cervical spines who've had long bone fractures before, if I really think that their cervical spine exam is reliable. Age. Can you use NEXUS criteria for every age? Jasmine says no. What age can you use NEXUS criteria for? All right. So the study enrolled patients from age range 1 to 101. That's everybody, all right? So they enrolled everybody. The problem is the number of patients who were 8 years with a cervical spine injury was very low. That made up only 1.3% of the cervical spine injuries. So while the authors of NEXUS originally would have stated it was okay to use in peds, subsequently peds emergency people might argue not to use it in the very young patients. All right, so this is a little bit debatable, but I would say that using NEXUS in kids 8 years and younger is a little bit sketchy. And there might be some other things that you might consider doing, which is basically other studies have suggested just that if a kid 8 or younger says they have neck pain, even if they would otherwise pass NEXUS criteria, you probably just proceed with imaging of their neck. And if they can't rotate their head left and right, you should probably just proceed with imaging their neck. And so there isn't really a specific rule to use in those little pediatric patients. Secondly, is that subsequent studies found that NEXUS sensitivity decreases as you get older. And so patients who are very elderly, there is some chance that you may miss fractures with NEXUS. And that brings me to a sort of tangential thing, but that's important to discuss here, which is the Canadian CT, the Canadian C-spine rule. All right, so the Canadian C-spine rule has been compared to NEXUS, and that was done in New England Journal of Medicine 2003. And the Canadian C-spine rule actually outperformed NEXUS. It had better sensitivity and it had better specificity. So why do I not use the Canadian C-spine rule? Well, number one, I'm American, not Canadian. This is true. I did med school in the United States, and I learned the NEXUS rules when I was in med school, and in residency, my attendings taught me NEXUS and not Canadian. But there's another reason, that's the more practical reason, which is that the Canadian C-spine rule is wicked hard to remember. I bet that not a single person in this room has it memorized. So there's a whole bunch of steps to it, and really the only practical way to use it, unless you have spent a long time memorizing all the details of it, would be to use a medical app. If you use an app and you go through it, you can probably do it, but it's a bit complicated. And so for me, when I'm assessing for cervical spines multiple times every day, which really we do, then using something that's as complicated as the Canadian C-spine rule is not practical to me. But the things that I take away from it, one thing in the Canadian C-spine rule is that everybody in the Canadian C-spine rule, 65 and older, gets imaging of their cervical spine if they have a blunt trauma that could have potentially sustained an injury to their cervical spine. Everybody, all right? So I was just telling you NEXUS sensitivity seems to drop in the elderly, and the Canadian rule says to image everybody, 65 and up. And so for me, in some cases, even if they would pass NEXUS criteria in the elderly patient, I'm going to probably proceed and get imaging of their cervical spine. Under 65, I directly follow NEXUS. Even if it doesn't have 100% sensitivity, nothing does. It's easy to apply, and it is extremely sensitive. Validated in 34,000 plus patients. All right? The last component here is X-ray versus CT. So I already talked about how NEXUS was derived mostly with X-ray and probably has a little bit lower sensitivity as a result than is quoted in that big study. But that's okay. And the issue with NEXUS, though, is not really whether to get an X-ray or a CT. NEXUS says, do you image them or not? If the patient does not pass NEXUS criteria, it is then your decision if you want to do an X-ray or a CT scan. NEXUS does not tell you what type of imaging they need. It just tells you that they should get imaging. And in modern day emergency medicine, CT scan is definitely favorable for most patients. I would still argue that in patients who are extremely low pretest probability, especially like young patients, I will still get x-rays. And I see a 20-year-old who's ambulatory and has no neurologic deficits with a minor mechanism of injury, even if they have some midline cervical spine tenderness and wouldn't pass NEXUS, I'm okay getting a plain film x-ray on that patient. But other providers will say, I want the best test every time, and they'll do a CT scan every time. So you'll have to decide when you become an attending how you want to play that out. It is my opinion that really low pretest probability patients could probably just get an x-ray. Certainly elderly patients or patients with higher mechanisms, more likely to have fractures, I would get a CT scan. Questions about that? All right. So that's it for NEXUS. Just a couple last points about clinical decision rules in general. So to make a clinical decision rule requires at the minimum 2 studies, or to make a clinical decision rule that you should use requires 2 studies. It requires a derivation study and then a validation study. So the study that I sent you was the validation study. The rule had already been developed, and then they tested it, and it worked. But before that must come a validation study, before that must come a derivation study. The derivation study was in Annals of Emergency Medicine 1992. It took them 8 years in between the time it was derived to the time that NEXUS criteria validation was finally published. So developing this relatively simple rule took more than honestly 10, 15 years of work. All right, so this is like nearly lifetime type accomplishment for the authors from this study. The main author, by the way, Jerry Hoffman, hopefully at least some of you know who that is, big name in emergency medicine, works in LA, in like big into like medical education and podcasting and so forth. All right, so the point here, that clinical decision rules must be validated after they are derived. So you need to have 2 studies if you want to apply a clinical decision rule into your practice. After the rule is derived, you want to say, has the rule been tested? Has the rule been validated? And NEXUS has. But some other rules out there, for example, the Larinic score, I don't know if you ever heard of that, it's for necrotizing soft tissue infection, never validated, only derived. So if you're going to use a rule that hasn't ever been validated, basically you probably shouldn't. You might use the information to help you assess the patient a little bit more, but directly following a rule that has not been validated is not advisable. All right. There are 2 types of clinical decision rules, 1-way and 2-way. So NEXUS is a 2-way rule, which means this. If you have a blunt trauma patient and they pass all the NEXUS criteria, you don't image their cervical spine. But if they don't pass all the NEXUS criteria, you do image them. So it tells you one way or the other. You do this or you do this. Two things. Opposite of that, though, is a 1-way rule, which is like the PERC rule. So you apply the PERC rule, and if all the PERC criteria are met, you don't test them. But guess what? If somebody doesn't pass all the PERC criteria, it doesn't mean that you have to test them for a pulmonary embolism. Do you see how that works? Otherwise, every single patient over 50 would have to be tested for a pulmonary embolism based upon the PERC criteria. All right? So the PERC is a 1-way rule where if you meet everything, you don't test, but just because you don't meet the PERC criteria doesn't mean that you do test. Nexus, though, goes both ways. If you meet all the NEXUS criteria, you don't have to test. But if you don't meet all the NEXUS criteria, you should test. All right? That's the difference between a one-way and a two-way rule. Any questions about any of that? Nope.